In this video, we are going to discuss about postoperative shivering, incidence, causes and risk factor of postoperative shivering, the basic of thermoregulatory physiology like the core body temperature, how hypothermia signals being transmitted, body's efferent response to hypothermia, perioperative hypothermia, the sites for measuring core body temperature, risk factor for postoperative shivering, non-thermoregulatory factors, management of postoperative shivering, as well as the clinical significance of it. Postoperative shivering. Postoperative shivering refers to involuntary oscillatory contraction of skeletal muscles that can occur during recovery from anesthesia. It is usually seen in 5 to 65% of patients undergoing general anesthesia, and for regional anesthesia, it is seen in the 30 to 33% of cases. The most common cause of postoperative shivering is the hypothermia. The hypothermia is due to the exposure to a cool environment during the surgery in the operation room theater. Heat loss occurs via the radiation, convection, evaporation and conduction. It may be also due to the inhibitory effect of anesthetic agents on the thermoregulation. Shivering can also occur in patients with normal body temperature due to the other factors known as non-thermoregulatory factors such as pain, surgical stress, and the effect of certain anesthetic drugs, particularly short-acting opioids like the remifentanil, which can lead to acute opioid withdrawal symptoms and hyperalgesia. Regional anesthesia blocks sympathetic activity. Thus, there is parasympathetic overactivity noted. Due to the sympathetic blockade, there is vasodilatations noted below the level of the sympathetic block. That leads to cooler peripheral blood redistributed to the core body area that decreases the core body temperature. Regional anesthesia decreases shivering and the vasoconstrictive threshold by 0.6 degrees centigrade. Core body temperature represents the temperature of the body's internal organ, such as heart, brain, liver, and the other vital organs, including blood. The normal core body temperature is about 37 degrees centigrade or 98.6 degree Fahrenheit, and this temperature usually 2 to 4 degrees centigrade warmer than the skin temperature. The core body temperature usually maintained within a narrow range 36.5 degrees centigrade to 37.5 degrees centigrade. If the core body temperature is outside of this interthreshold range, the hypothalamus initiates homeostasis and the behavioral mechanism to return the body to normothermia. The strict temperature control is important for normal organ, enzymatic, and the cellular function. In patient with hypothermia, the low temperature is detected by the thermal sensors. Thermal sensors are the heat and the cold sensitive cells that are located in the hypothalamus, brainstem, spinal cord, deep abdominal tissue and the thoracic tissue, as well as in the skin. Then the signal is transmitted via the afferent fibers like the A delta fibers for the cold receptor and the C fibers for the warm receptor to the central thermal regulators. Central thermal regulators are hypothalamus and the spinal cord. That causes efferent response to hypothermia. Behavioral modification like wearing more clothings, relocating to a warmer places, vasoconstriction, shivering, that is mainly occur in the adults. Due to the shivering, there is increased muscle work. Increased muscular activity causes heat generation. As the metabolic rate increases to about 6 times than its basal metabolic rate. In neonates, there is non-shivering thermogenesis that mediated by beta-3 adrenergic receptors in the brown adipose tissue. As in the brown adipose tissue, there is increased mitochondria that causes increased lipid oxidation to generate ATP and heat. In about 20% of the patients who are undergoing surgery experiences unintended perioperative hypothermia. When the core body temperature is less than 36 degrees centigrade, it is called the hypothermia. Hypothermia can be classified as mild when the temperature is between the 32 to 36 degrees centigrade, moderate when the temperature is between 28 to 31.9 degrees centigrade, severe when the temperature is less than 28 degrees centigrade, and profound hypothermia called when the temperature is less than 24 degrees centigrade. where to measure the core temperature. We can get the accurate core body temperature when we measure the temperature at the tympanic membrane. The other sites for the measurement of the core body temperature are axillary, rectal, and the nasopharyngeal temperature. But here the reading may be less accurate, as in these places there is underestimate core temperature recording noted. Risk factors for postoperative shivering. Anesthesia related factors. Type of anesthesia. General anesthesia can impair the body's central thermoregulation, making patient more susceptible to temperature fluctuation and shivering. Neuraxial anesthesia, like the spinal or epidural, affects both the central and the periphery thermoregulation, leading to heat redistribution and increased heat loss. The combined general and the regional anesthesia causes much more loss of the core body temperature and increases the risk of shivering. Anesthetic medications like the volatile anesthetics and opioids can significantly impair the thermoregulatory control and lower the threshold for shivering. Short-acting opioids like the remifentanil can lead to acute opioid tolerance, and hyperalgesia increases the likelihood of shivering after discontinuation, the cause of which will be discussed later. Surgical factors. During surgery, longer duration of surgery, usually more than 60 minutes, increases the risk of shivering, possibly due to the prolonged exposure to the operating room environment, which is usually cooler, and greater heat loss. Certain surgeries, like the major surgeries, major intra-abdominal surgeries, thoracic surgeries, this all increases the shivering threshold due to significant surgical invasion and the associated factors like the blood loss and the fluid shift. Substantial blood loss during surgery can also increases the risk of postoperative shivering. Patient undergoing emergency procedures may have a higher risk of shivering compared to those undergoing elective surgeries. Patient factors. Younger age is a known risk factor, while shivering intensity tends to be reduced in older and the frail patients. Women have a slightly higher incidence of shivering than the man. Higher body mass index is associated with the reduced risk of postoperative shivering. Thus, the lean patient and the malnourished patient have increased risk of shivering postoperatively. Preoperative anxiety can increases the risk of shivering. Postoperative pain can also facilitate non-thermoregulatory shivering. Temperature-related factors. Hypothermia is a common trigger for shivering, as the body attempts to generate heat through the muscle activity. Studies have shown a strong association between the lower core body temperature at the end of the surgery and the increased risk of shivering. Low peripheral temperature. Even with maintained core temperature, a lower peripheral temperature can increases the risk of shivering, as during anesthesia there is vasodilatation that decreases the gradient between the periphery and the core body temperature. Thus, the low peripheral temperature also decreases the core body temperature during anesthesia. A significant difference between the core and the periphery body temperature can also contribute to shivering. Ideally, the core to peripheral temperature difference should be maintained below the 4 degrees centigrade. Fluid management. Intraoperative fluid volume and the temperature of the fluid can play a role. Using unwarmed irrigation fluid can predispose patient to hypothermia and shivering. The mechanism for the development of postoperative shivering. The most common cause of postoperative shivering is the hypothermia. The postoperative hypothermia occurs secondary to the heat loss during the surgery. Heat loss occurs via the radiation, convection, evaporation, and the conduction. Postoperative shivering is usually due to the hypothermia. Thermoregulatory mechanism can explain shivering in the patient with hypothermia. But the hypothermia is not the only cause for shivering. A number of different mechanisms have been proposed to explain shivering in normothermic patient. One proposed mechanism is based on observation that brain and spinal cord do not simultaneously recover from general anesthesia. The more rapid recovery noted at the spinal cord function. Rapid recovery of the spinal cord function causes uninhibited spinal reflexes that exhibited as clonic activity. This theory is also supported by use of doxapram. It is a central nervous system stimulant As the spinal cord recovers faster than the brain, so we have to stimulate the brain. And by using this doxapram, there is stimulation of the CNS occur. Then the CNS can match with the spinal cord function. So there is abolished postoperative shivering occur. The other proposed mechanism include action on kappa opioid, NMDA, that is N-methyl D-aspartate, and 5-hydroxytryptamine receptor. The higher incidence of post-anesthetic shivering in patients who received high dose of remifentanil is thought to be by the same mechanism that causes hyperalgesia in this patient. Sudden opioid withdrawal resulting in the stimulation of the NMDA receptor that can lead to shivering. A small dose of intraoperative ketamine. Ketamine is a NMDA receptor antagonist that reduces the incidence of remifentanil-induced postoperative shivering, as the remifentanil withdrawal causes stimulation of the NMDA receptor and the ketamine is a NMDA receptor antagonist. So ketamine suppresses the stimulation of the NMDA receptor due to the withdrawal of remifentanil. Thus, there is decreased shivering. Tramadol, a weak mu-opioid receptor agonist, and norepinephrine and serotonin reuptake inhibitors that has been shown to be effective in prevention of postoperative shivering. Interventions include identification and treatment of hypothermia if present. Accurate core body temperature can be most easily obtained at the tympanic membrane. Forced air warmers are used to warm the patient with hypothermia. Skin contour warming is highly effective in most patients and can significantly reduce the dose of anti-shivering drugs. The drugs used are magnesium, bolus 4 to 8 gram over 10 to 30 minutes, or magnesium drip can be used as 0.5 to 1 gram per hour, buspirone 15 to 60 mg by mouth, ondansetron 8 mg bolus given once, meperidine. This is the most commonly used drug for the prevention of postoperative shivering. The dose is 12.5 to 25 mg IV. Fentanyl can also be used. The dose is bolus 12.5 to 50 microgram or in drip 50 to 200 microgram per hour. Dexmedetomidine also shown to be effective as a prophylactic measure. The dose is 0.5 to 1 microgram per kg as a loading dose, then 0.2 to 1 microgram per kg per hour as maintenance dose. Clinical significance: postoperative shivering leads to significant patient discomfort due to the shivering, as there is increased muscle activity. For that, there is increased oxygen consumption and increased carbon dioxide production. This shivering also leads to increased sympathetic tone, and it is associated with increased cardiac output, increased heart rate, increased sympathetic blood pressure, as well as there is increased intraocular pressure. Mild to moderate hypothermia, when the temperature between the 33 to 35 degrees centigrade, that inhibit the platelet function, coagulation factor activity, as well as the drug metabolism. Decrease in the hepatic and the renal blood flow causes decrease in the metabolism and the excretion of the drugs. Thus, there is prolonged drug effect noted. There is also decreased hepatic metabolism that prolonged the action of propofol and the opioid. Shivering also exacerbates postoperative bleeding, prolonged the neuromuscular block duration as due to the decreased hepatic metabolism, decreased rate of Hoffman degradation, changes in the volume of distribution, pH changes noted at the neuromuscular junction that may lead to delay awakening or delay recovery from anesthesia. Tissue solubility of the volatile anesthetics increase that also delay in recovery. All this leads to prolonged stay in the postoperative care unit. Long-term deleterious effects include an increased incidence of myocardial ischemia and myocardial infarction, delay wound healing that is secondary to the decreased subcutaneous tissue blood flow, decreased oxygenation, as well as decrease in the immune function. Also, there is increased risk of post-surgical site infection. Postoperative shivering may also increases the perioperative mortality.